Hello and welcome back to my channel. In the previous video, we talked about the extradural hematoma, and this one we will talk about the acute subdural hematoma. And it's called acute obviously because there is chronic subdural hematoma. We'll take a quick review. Okay, so in today's video, we are going to talk about the meningeal layers, the meninges of the brain, and some general info and causes of the acute subdural hematoma itself. We're going to talk about the CT scans and the sites of the acute subdural hematoma. We are going to compare between the extradural hematoma and the acute subdural hematoma. And we will also take about the indications for surgery, the type of surgery that you are going to do. And there is a little quiz in the end of this video. So as you can see here in the axial CT scan on this slide, there is a hyperdensity, a whitish thing, okay, that is lining the bone from the inside. The brain itself is being pushed to the other side. The brain itself is being pushed to the right side. So there is a midline shift. You can see here a small hyperdensity as well, but this one is the most concerning because the brain is being pushed to the other side. Okay, so let's take a look at the meninges. So you have here the scalp, and in the previous lecture we talked about the layers of the scalp. The S stands for skin, then C for connective tissue, A for the aponeurosis or gallia, and the L is for the loose connective tissue layer, and then the P for the periosteum that surrounds the skull. Okay, and then you have the skull bone surrounded by two layers of periosteum, outer table and inner table. Then we'll have the meninges, which are the layers that surround the brain itself. Okay, so from inside to outside, you will have the pia mater, which is adherent to the brain. As you can see here in the pinkish color, it surrounds all the sulcine gyri of the brain. And then we have the arachnoid matter with the layer with the space between them is called the subarachnoid space, meaning beneath the arachnoid matter. Then in the blue color here we have the dura mater. Okay, so the dura mater is actually separated into two layers, the periosteal one and the meningeal one. Okay, and we have here a space called the subdural space. So we have two spaces, the subarachnoid space in which the CSF is found, and then we have the subdural space, which is a potential space between the two layers, the dura mater and the arachnoid mater. And we will talk about that in a minute. So the type of hematoma that we are going to talk about is between the dura mater and the arachnoid mater. Okay, so let's jump into the lecture to talk about the acute subdural hematoma itself. They say it's much more lethal than the extradural hematoma because there is often underlying a brain injury. So the brain injury happens. If the brain injury happened, the hematoma obviously will become much more lethal. Because as you can see in the extradural hematoma, there was no brain injury at all. The injury was to the bone, and the blood accumulates that pushes down the brain or pushes the brain to the other side. But in this one, in this acute subdural hematoma, the brain injury itself is the main cause of the deterioration of the patient. So obviously it will become much more lethal. It will become much more killable. Okay, not killable. It will become much more. It can kill the patient more. Okay, so pardon my English. So there will be no lucid interval because the hematoma itself is not accumulating. The hematoma itself is because of the brain injury. The brain injury itself caused the hematoma. So there will be no lucid interval, no space for you to think. Okay, and there are two common causes of the acute subdural hematoma. These causes are, number one, are the accumulation of blood around the brain laceration. So the brain injury happens, then the vessels or the small blood vessels in the brain itself will do the accumulation of blood. The blood will accumulate in the subdural space without a lucid interval, as we said. The second one is the most important one. It's called acceleration, deceleration, violent head movement. Okay, so let's say someone is driving a car and he had a motor car accident and the car suddenly stopped. If the car suddenly stopped, the bouncing of the head of the patient or of the injured person will lead to injury of what's called bridging vessels. Okay, so it's called acceleration deceleration because it mostly happens in the car accidents, and the leading it leads to the injury of the bridging vessels, and the bridging vessels, as you can see here, are found between the arachnoid and the dura mater. There are some vessels which are bridging from this layer to this layer, okay? And I have a picture of that. Okay, so as you can see here, the dura mater is in yellow color, and the arachnoid matter is this thin black color, okay? This thin black line, and the white space here is called the subdural space. And as you can see, there are some major veins, okay? So these two veins are called bridging veins. Bridging meaning that they are forming a bridge in the subdural space. This large one is a bridging vein as well. So if any damage happens here in the bridging veins, blood will accumulate here in this space, in the subdural space, that will cause the subdural hematoma, okay? So we have two common causes: the accumulation of blood around the brain laceration itself, and the acceleration deceleration one, which will cause damage to the bridging vessel. But here in the causes we have a major thing, okay? If the patient was on anticoagulation therapy, that may cause the subdural hematoma without even a major, let's say, injury or a major accident, okay? So to differentiate between this and the extradural hematoma, the extradural hematoma will happen to the young adults, okay, a 20-year-old adult. But this one happens to the patient who are on anticoagulation therapy. So you may find it on a like 70-year-old patient with a minor injury. Let's say he fall onto the ground on his home, okay, in his home, but he is taking anticoagulation therapy. So the acute subdural hematoma might happen in this patient. You might see it in elderly patients more than the young patients, okay? So just keep this in mind. Okay, so if we are going to talk about the CTs and in the acute subdural hematoma and the sites of the acute subdural hematoma on CT, okay? So as general info, the acute subdural hematoma will be hyperdense. Hyperdense meaning it is more white compared to the brain. The brain will be more grayish, okay? And edema in the adjacent brain may present, okay? So we will talk about the edema much more in other lectures, but just keep that in mind, okay? So as for the sites or locations of the acute subdural hematoma and the CT, we have 4 locations, okay? The first one, the most common one, is the convexity. Convexity means that is adjacent to the convexity of the skull itself, okay? So it will be crescent in shape, so a crescentic mass of increased density adjacent to the inner table. So it is adjacent to the inner table of the skull. It will be crescentic in shape. It takes the shape of the dura itself, okay? So a crescentic hyperdense mass, as you can see here in the coronal image, it is a crescentic hyperdense mass, okay? This is the first type. Then we have 3 more types which are less common, okay? You will see this convexity type in like 99% of the patients. These 3 types are less common, but you need to keep them in mind. The interhemispheric one, between the 2 hemispheres, as you can see here, there's a hyperdensity between the 2 hemispheres. And we have layering the tentorium. Layering the tentorium, as we talked about in the previous lecture, the tentorium cerebelli is a dural fold that lines the cerebellum. So this hematoma here, as you can see, is lining the tentorium, is above the tentorium, okay? And this is the axial photo of the same picture. This hematoma is above the tentorium cerebelli. And the last one, it can happen in the posterior fossa, okay? So as you can see here in this picture, this is the interhemispheric one. This is another picture of it. And this one is in the posterior fossa. So as you can see, this is the cerebellum, and this is the tentorium, okay? And the hematoma itself lies underneath or within the posterior fossa at the cerebellum level, and this is the axial image of the same patient, okay? So to remember the types, we have the convexity type, which is the most common. It will be a crescentic mass, okay? Then we have interhemispheric type, we have the tentorial type, and then we have the posterior fossa type, okay? Okay, so let's jump in to compare between the extradural hematoma and the acute subdural hematoma. So as we said in the previous lecture, the extradural hematoma will be biconvex in shape or lenticular in shape, but the acute subdural hematoma will mostly be crescentic, would resemble a crescent because it lines the dura from the inside, okay? the extradural hematoma will be uniform in density. All of the hematoma itself will be the same color, okay? But this acute subdural hematoma will be less uniform. As you can see, it is less dense. It has less density than this one. And as you can see, it has like gray streaks in it, okay? These gray streaks are because the blood itself is transforming to a chronic blood, okay? And we will talk about the chronic subdural hematoma in another lecture. But as you can see here, it is less uniform, okay? And that's a major differentiation thing, okay? The acute subdural hematoma, the extradural hematoma, sorry, it can cross the intradural barriers, okay? As we said, it is above the dura, so it is not connected, or it is not related to the barriers of the dura inside the brain. But this one cannot cross the intradural barriers. As you see here in this image, it is lining the dura from the inside, but it cannot cross to the cerebellum. It cannot cross the tentorium cerebelli because it is lining the dura. Okay, so this is the difference between the extradural hematoma and the acute subdural hematoma. Okay, and now let's talk about the indications for surgery. Obviously, we'll do surgery for the acute subdural hematoma. We'll do evacuation, and I will talk to you through about the type of surgery that you are going to do. But for now, let's talk about the indications of surgery. The indications are three in number. Okay, so if acute subdural hematoma with a thickness of more than 10 millimeters or midline shift more than 5 millimeters, should be evacuated regardless of the GCS. So if you have a fully conscious patient, but he has a midline shift of more than 5 millimeters, obviously he will not be fully conscious, but let's say he is fully conscious and he has a midline shift of more than 5 millimeters or a thickness of more than 10 millimeters on CT, then the hematoma should be evacuated, okay? But if the thickness was less than 10 millimeters or the midline shift was less than 5 millimeters, so the patient will undergo evacuation if, okay, if the GCS drops by more than 2 points from the injury to the admission. So if you saw the patient in the ER, performed your CT, and let's say in your first assessment of the patient, the GCS was 14, okay? But after the patient did the CT, after like 2 hours, the GCS of the patient became like 11, okay? So there is deterioration of the patient. The deterioration will make the surgery more appealing, okay? So you should do surgery even if the hematoma itself was not large enough or the midline shift was not big enough, okay? Or if the pupils of the patient were asymmetric or fixed or dilated, you should also do the surgery because of the pupils. Let's say the right pupil was dilated at the examination. This means that there is brain injury. There is mass effect of the hematoma on the brain itself. So this patient might undergo surgery. And if the ICP, the intracranial pressure, was more than 20 millimeters mercury, this patient will undergo the surgery. Okay, this specific indication is not as much of important because the ICP itself is measured in the ICU or in the operating room. It is not measured in the ER, so it is really hard to determine if the ICP is high or not. But there are some signs of the high ICP, which is vomiting or disturbed level of consciousness, and we will talk about the increased intracranial pressure in another lecture. But just memorize this for now, okay? And all the patients with acute subdural hematoma and GCS below 9 the ICP of this patient should be monitored, because if the patient is not surgical, let's say if the patient does not meet the criteria or the indications for surgery, but his GCS was 9 or below 9, he is intubated, he is in the ICU, you should monitor the intracranial pressure of the patient, because if it rises more than 20 millimeters mercury, then this patient will undergo surgery, okay? So these are the indications, just memorize them, okay? and there is we should focus on the timing of the surgery itself, okay? Because acute subdural hematoma, if it was meeting the surgical criteria, it should be evacuated as soon as possible, okay? But in research they found what is called the 4-hour rule, okay? So if the surgery was performed in the 4-hour time frame, it will be more beneficial to the patient, because they found that if the patients operated within 4 hours of the injury, will have 30% mortality compared to 90% mortality of the if the surgery was delayed to more than 4 hours. Okay, so the mortality of the patient is 90%. Okay, because we talked about that the acute subdural hematoma is more lethal. Okay, but if you performed the surgery within 4 hours from the time of the injury, not from the time of admission, okay, the mortality rate will drop to 30%, as well as the functional rate of the functional survival rate will be 65%. Okay, 65%, that means that the patient will be functional, the patient can take his own breath, the patient will not be handicapped or something if the surgery was performed in 4 hours from the time of the injury. Okay, so the 4-hour rule is very important, you should keep that in mind. Okay, now let's talk about the type of surgery that we will need to do. Okay, the surgery itself is called a decompressive craniotomy, and from the name, decompressive means we'll do decompression of the brain. We will relieve the compression on the brain, and craniotomy means removal of the bone. Okay, so as you can see here in this picture, we have the skull layer which is clipped. We have this muscle which is the temporalis muscle. Then the stitched layer will be the dura mater, and under the dura mater you'll have the hematoma itself. So as you can see here, the surgeon is trying to evacuate the hematoma, and if he found the bleeding vessels, he will try to cauterize them without doing a brain injury. Okay, and in this type, or in these types of operation, the bone itself after removal, you may find that the brain itself may need more decompression. Okay, so in some cases we may put the bone itself, the bone flap itself, in the abdomen of the patient, or in a bank or something, to just relieve the pressure on the brain, to let this area like breathe. Okay, so the bone of the patient will be left inside his abdomen, and this area will be left bare, there will be no bone, and the bone flap can be returned after like 3 to 6 months of the operation. Okay, and as you can see here in this picture, this is a post-operative picture. The bone flap, a part of the bone was removed from the head of the patient to relieve the pressure, to decompress the brain. Okay, and as you can see here in this picture, the midline shift has gone. Okay, so the midline is in good condition, the ventricles are visible. Okay, the gyri and the sulci of the brain are visible again. Okay, so this is a good decompression of the brain, and that is the goal of the surgery. Okay, after we talked about the types of acute subdural hematoma, the CT scans, the indications for surgery. Okay, now let's take a quick quiz. Okay, so this quiz, you can pause the video and you can read it. Okay, it's really long, but we will take the important points. Okay, so it's a 20-year-old male patient, he had an accident. Okay, his GCS on arrival was 3, so it's really low. Okay, pupils, they were both equal and reacting. Okay, so after arrival, the patient was intubated and ventilated, but the GCS was around 3. Okay, and the pupils, the right one constricted to light, but the left one does not. So the left pupil was dilated. Okay, and it was fixed, and that one of the indications for surgery. Okay, so the left pupil was fixed, and you should work around that. Okay, so the CT scan of the patient, that is the one CT scan from the first slide. Okay, as you can see here, there is a hyperdensity, a crescent shape hyperdensity, so it's convexity acute subdural hematoma, and there is midline shift, so the brain is being pushed to the other side. And here you can see another hyperdensity, but it is not important as this one, because the brain is shifted to the right side, okay? So the patient will need decompressive craniotomy for this side, okay? And actually this image is for the same patient who had the decompressive craniotomy, and as you can see here, the midline shift was relieved and the acute subdural hematoma was evacuated correctly, okay? So we have three questions. You can like pause the video, okay, and you can answer the questions in the comment section. The first question is, describe the appearance on the CT scan. We described it, okay. The second question is, explain why this is not an extradural hematoma, and then you can go back to the slides of the comparison between the extradural hematoma and the acute subdural hematoma, okay. And the third and final question is, what is the definitive management of this case? So to make it clear, yeah, decompressive craniotomy, okay. Okay, so that's been it. Thanks for watching.